Thank you everyone for staying and attending the session. I'd like to introduce Dr. Poluto first. He is an assistant professor of medicine and oncology at the Mayo Clinic in Rochester. He completed his medical degree in Brazil, followed by internal medicine residency, Hem/Onc fellowship, and advanced lymphoma fellowship at Mayo Clinic. He is currently a member of the Lymphoma, Cell Therapy, and Stem Cell Transplant Disease Group within the Division of Hematology. His research work focuses on translational outcomes research in lymphoid malignancies and implementation of novel technologies in the management of patients with cancer. He is the PI of several clinical trials, ranging from early therapeutics to platform projects exploring the use of wearable devices and remote patient monitoring.
Thank you for the kind introduction. And also thank you, the organizing committee, for the invitation to review today some of the highlights on lymphoma and cell therapy group. It's my research disclosure. These are my disclosures. So there's been, the lymphoma space is very broad and diverse, with more than 60 different subtypes of lymphoma. And I can't really cover everything in 15 minutes. So I selected a few different trials to review today that, in my opinion, have the most promising impact in clinical practice, either soon or in the near future, and also filling some of the gaps in knowledge in clinical practice. I will start with the Elari study. So this is in the cell therapy space. So the Elari study was looking at Tizacel, which is an autologous anti-CD19 CAR T cell product in the relapsed refractory follicular lymphoma population. So those are patients with grade 1 to 3A lymphoma, follicular lymphoma with at least 2 prior lines of therapy, including a CD20 monoclonal antibody and an alkylator agent. Patients had to be refractory to one of the prior lines of therapy, including progression during the prior treatment or within 6 months from completion of therapy. It was a phase 2 study. Bridging therapy was allowed, and there were 2 different lymphodepleting chemotherapy options. One was Flu/Cy, which is the usual and used in clinical practice, but also bendamustine for 2 days was allowed. So 98 patients were enrolled, with 97 being treated. The median age was 57 years, which is a little younger than the overall for this patient population. Most patients had a high Philippe score, and the median lines of therapy were 4. Interesting, 78% of the patients were refractory to the very previous line of therapy. And the median follow-up was only 10 months. But with that, we have a CR rate of about 66%, with an overall response rate above 80%. Interesting, we also saw here a partial remission conversion to CR in 40% of the patients, approximately within 6 months from CAR T, which is a par with what we see in a large B-cell lymphoma space. The adverse events or the safety profile was very similar to what we expect to see in this population, with some hematologic adverse events in about 30%, up to 30% of the patients. Cytokine release syndrome was seen about half of the population, with none of those being grade 3 or higher, and neurotoxicity in about 90%, with only 1 patient with grade 3 or more. So overall, compared to what we have in CAR T today in the large cell lymphoma space, Tizacel had lower rates of adverse events, especially lower rates of CRS and neurotoxicity. So with 1 product already approved for follicular lymphoma patients, Axi-cel, I think Tizacel will be the second product to be approved soon to be used in this patient population. So moving on to the multiple myeloma space in cell therapy, I want to talk about the KarMMa study. There are some updates at ASCO recently. So the KarMMa study looked at Ida-cel, which is an anti-BCMA autologous CAR T product, was looking in relapsed refractory myeloma patients with at least 3 prior lines of therapy, including proteasome inhibitor, IMiD, and daratumumab. It was another phase 2 study. Bridging therapy was allowed, and you can see here the lymphodepleting chemo was Flu/Cy at slightly higher doses than follicular lymphoma. 140 patients with 128 being treated, but only 1 was not due to manufacturing failure. Some of the highlights from the original publication in the patient population, as you can see, the median age was 61, which is the average for this patient population. There was about a third of the patients with the high-risk cytogenetic features, Most received bridging therapy, and most also had prior transplant, which is what we expect to see in myeloma patients. But I want to highlight that a lot of patients were double or triple refractory prior to CAR T. The median follow-up was just over a year. The overall response rate was 73%. Now, if you include everybody that was enrolled in the intention to treat analysis, that was 67%, with about a third of the patients achieving a CR or a stringent CR. Interesting, the MRD negativity rate was about a quarter of the patients, or 26%. Just showing the couple of markers for PFS and OS. The median PFS was 8.8 months. And with updated results from this most recent ASCO, and now with a longer follow-up, we see that the median PFS did not change as expected, with a 15-month overall survival was just over 70%. As far as safety goes, there was a lot of cytopenias, which is expected to see in the CAR T space due to lymphodepleting chemotherapy. The rates of cytokine release syndrome and neurotoxicity was also within expected as what we see these days in the large B-cell lymphoma space. But most of those were low-grade CRS and neurotoxicity. So moving on to the next study. So we also had the data from the CARTITUDE-2 study of the cohort A of CARTITUDE-2 study presented recently. Another anti-BCMA autologous CAR T product that was evaluated in the multiple myeloma population now with prior 1 to 3 lines of therapy. So the KARMA was after 3 lines of therapy. The CARTITUDE is looking at CAR T a little earlier in the disease course of myeloma patients. Another phase 2 study, and the lymphodepleting chemo here was a flu-cy only, with a primary endpoint of MRD negative. So there were only 20 patients. Median age was similar to the prior study, as I mentioned. The median prior lines were only 2, but most patients had prior alkylating agents. The majority also had daratumumab, and they were triple refractory in 40% of these patients. The median follow-up is still quite short, of 5.8 months only. The overall response rate is 95%, with a lot of CRs and stringent CRs. I was a little bit disappointed to see only 4 patients with MRD available samples, but all of those 4 patients had MRD negative disease. As far as safety goes, nothing unexpected. A lot of hematologic adverse events with lymphodepleting chemotherapy. The CRS and neurotoxicity rates here are very similar to the ones seen in the KARMA study. There was 1 death reported due to COVID. So overall, with these 2 studies with CAR T in myeloma, we see deep responses, but we see a short PFS so far in the KARMA. It will be important to have a longer follow-up in the CARTITUDE-2 study to have a better idea of PFS. And I also want to see more data on the MRD negativity results. So this off-the-shelf CAR T, this is not quite ready for clinical practice, but I think the field is moving towards that direction. There was 1 nice study on off-the-shelf CAR T, which was the ALPHA study. Look at a product called ALLO-501, which is a CD19 allo CAR T product. It has a T-cell receptor gene disrupted to prevent GVHD. Now, this study also uses anti-CD52 monoclonal antibody as part of the lymphodepleting chemo. So they also disrupted the CD52 gene in the CAR T product to prevent it from being destroyed by the CD52 monoclonal antibody. The patient population here are relapsed refractory B-cell, large B-cell or follicular after 2 lines of therapy, which is the current field or space where CAR T has been used in clinical practice. So phase 1 single arm study. The lymphodepleting chemotherapy here was flu-cy with the anti-CD52 monoclonal antibody. They're looking at safety and tolerability as a phase 1 study. There are only 12 patients, with only 9 being treated. About half large B-cell lymphoma, half follicular, with three prior lines of therapy in average. Short follow-up, but important, there were no GVHD cases in this small number of cases, and the overall response rate of close to 80% is what we expect to see with the current products available commercially. There are no really safety signals. Actually, I was surprised to see a lower number of hematologic toxicities than what I was expecting. Only 2 patients had cytokine release syndrome, and only 1 patient had neurotoxicity. So again, off-the-shelf product, short follow-up, early phase study, but we are seeing that it may become a potential option for our patients, that you don't have to wait for the manufacturing period. That's what we have for the cell therapy. Thank you.
Next, I'd like to get my right card. I'm going to introduce Dr. Bird. I think he just joined Cincinnati recently. He's a doctor who probably does not need much introduction. He's an internationally renowned researcher and clinical specialist in leukemia and other hematologic malignancies, who now serves as the chair of the Department of Internal Medicine at the University of Cincinnati. He has over 600 publications in the area of leukemia and experimental therapeutic research. He runs a highly translational laboratory focusing on CLL and drug development in hematologic malignancies. He has been part of the successful development of multiple therapeutics in AML as well as CLL. So it's my pleasure to introduce Dr. Bird.
Thank you. It's great to be here. And I think I have exactly 30 seconds to keep us on time. So we'll try our best though. So in the next 10 minutes or so, I just want to introduce some practice-changing abstracts and some interesting abstracts that were at ASCO this year. And so these are my disclosures. So we'll start with CLL. And this study, the Elevate Treatment Naive study, was updated at ASCO as a poster. The paper was presented at ASH, and the paper published in the Lancet last year. And this was a large phase 3 study of Acalabrutinib obinutuzumab, and comparing to chlorambucil obinutuzumab, an older standard for CLL. The primary endpoint was progression-free survival. And this was an elderly patient group over 65 or having multiple comorbidities. The point of the study, that's of interest, is progression-free survival obviously was longer with both Acalabrutinib and Acalabrutinib plus obinutuzumab, but this represented the first study in CLL when you went back and did a retrospective comparison that showed that adding a second-generation CD20 antibody, obinutuzumab, improved progression-free survival. The survival difference had a trend as well, that 0.057, say, that was starting to separate from Acalabrutinib alone. This was a post-hoc analysis, but the data continued to look good. I think the other important thing is this study, comparing to chlorambucil obinutuzumab, showed that there was less expected cardiac toxicity than had been seen with Ibrutinib in other studies, as well as hypertension. So what do we conclude from this study? Acalabrutinib plus obinutuzumab is probably a better therapy than Acalabrutinib, and definitely both of those are better therapy than alkylator immunotherapy. The frequency of atrial fibrillation is lower, but it was still higher than was seen with alkylator-based regimens, suggesting even with a selective BTK inhibitor, there probably is a class effect of this drugs. And then really, to me, why this study sticks out is, again, it's the first BTK inhibitor study that showed an advantage to adding a CD20 antibody. And this is going to, I think, lead to several other studies, because not only did it add to the progression-free survival in this study, but you got deep CRs in 20 to 30% of patients that potentially would enable stopping therapy. And the studies looking at this are being designed at this time. Another practice, and this I believe is a practice-changing study, is one comparing Acalabrutinib to Ibrutinib. This is the Elevate Relapse and Refractory study. In this study, compared the first generation to a second generation BTK inhibitor in deletion 17p patients, or deletion 11q, who've had one or prior therapy, but no BTK inhibitor or BCL2 targeted agent. The primary endpoint of the study was similarity. So this was a non-inferiority study. And when you look at progression-free survival, you see the hazard ratio is 1. So it clearly hit that endpoint. The secondary endpoints were survival. And while there wasn't a survival difference, there's a trend toward overall survival. Other endpoints were cardiac events, and these were pre-specified. And there was a significantly lower rate of atrial fibrillation with acalabrutinib, and hypertension was also lower with this over time. This looks at some of the other, what I would say, irritating side effects that occur with ibrutinib that we've noted, again, a first-generation BTK inhibitor, and both bleeding, mild bleeding events, diarrhea, and arthralgia over time were less with acalabrutinib. So what conclusions do I pull from this study? Acalabrutinib had similar efficacy and improved safety. And this safety, translated into a hazard ratio of 0.82 that was not significant, but over time, we will see if these separate as patients are followed longer. Given these results, in my own practice, if I'm starting a new BTK inhibitor, I generally consider acalabrutinib. What about changing patients who are on ibrutinib? I generally don't do this. This is very complicated unless they're having side effects with ibrutinib. There's data, it's 2 controlled studies of changing, and that you can diminish the side effects in about 2/3 of the patients. The one silent intolerance that I will consider changing patients for is grade 3 hypertension if they're on 2 or 3 medications for their hypertension. And it started with initiation of the drug, because again, you can get patients off of their hypertensive medicines and potentially decrease the long-term risk. The last agent that was discussed at the ESH is Xanabrita. This is also a second-generation BTK inhibitor that has similar features of acalabrutinib. But it also can be given with a proton pump inhibitor, because the absorption is not dependent upon the stomach pH. The Alpine study was presented. This was a similar comparative study in relapsed and refractory CLL patients, but included all patients, not those that were high risk, that compared Xanabrita to ibrutinib. And at 15 months, the frequency of adverse events, atrial fibrillation in particular, was significantly lower. The response rate was higher, and the frequency of bleeding was lower. So the lesson I think one can take away from this preliminary presentation is that Xanabrita is another alternative second-generation BTK inhibitor that can be used if patients are intolerant to ibrutinib, or particularly if they need a proton pump inhibitor. There will be other randomized studies that are coming forth with Xanabrita and even some of the third-generation BTK inhibitors. So the last thing, the last abstract of interest for CLL was the Captivate study. And this asks the question, does ibrutinib plus venetoclax yield durable remissions with fixed duration therapy? The primary endpoint of the study was response rate, particularly CR and CRI. And this included younger patients who had intact organ function, and patients would receive 3 cycles of ibrutinib and then 12 cycles of venetoclax. There were 159 patients enrolled on this phase 2 study. It was representative of a typical upfront CLL patient population based upon the mutation status and 17p. When we look at the results, 90% of patients completed therapy with a CR/CRI rate of 55%. Almost everybody responded. A good number, say 2/3 or more, were MRD negative in the blood or bone marrow. And at 24 months, the progression-free survival was very impressive. 34 patients had high-risk disease where you would have had to have hospitalized them if you would have started with venetoclax. And by virtue of treating with ibrutinib for 3 months, virtually all were shifted to a lower risk and could be treated as an outpatient. Neutropenia and hypertension were common grade 3 events. But in general, this was well tolerated in a young and selected patient population. I think we piloted a triple regimen with obinutuzumab, venetoclax, and ibrutinib, and I just showed this. We published it last year, but it makes the point that these combinations are immunosuppressive. Even 9 months after follow-up, you don't see T cell. You see a much lower T cell number, and you really have to look hard to find an NK cell after patients have received these regimens. With that, infections and also secondary cancers might be increased. So the point that I would make is, when do I use these combination regimens with venetoclax and BTK inhibitors plus or minus a CD20 antibody? I do it on trial. People are calling and asking, and this is still not in the NCCN guidelines because the follow-up on all these combination studies are too short. Well, let's switch to AML. And say, there was a practice-changing study of giving venetoclax and azacitidine, and this abstract that was presented by Dr. Prats and colleagues asked the question, and I think it's a very important question: do patients retain a CR with MRD after one, and then looking over time, every 3 cycles of therapy, do better? And say one can see that those who attain an MRD level of less than 1 in 1,000 AML cells had improved duration of response, overall survival, and event-free survival as compared to the other group. And I think learning points from this, as we look at this abstract, though, is that most of our path labs outside of hematologics in Seattle don't really measure MRD and AML, so we have generally less sensitive assays. Mutational status, looking for genomic mutations may be an alternative, but this is challenging. And this paper looked at CR MRD at any point, early versus late. So patients could have gone into MRD 9 months into therapy, and that's really not helpful. And I think one point that comes forth from this abstract, though, is that patients that are MRD after venetoclax and azacitidine, if you have a way of measuring this, do poorly, and we need new targeted therapies for this. Another abstract, and this was in the B book, so the non-published book, but sometimes that's where you find the most interesting thing. And this is an important question I think nobody knows the answer to. And how do patients who have had prior HMAs, either an MDS or AML, do when you give Veneza? And there's absolutely no data. And this group looked at 17 patients in a retrospective series. Most of them had deletion 17p, which is a high-risk group for Veneza, and it had a couple of therapies either for AML or MDS. I think the important point is only 6% of patients responded to this. The progression-free survival was 2 months, and the overall survival was 3 months. No patients could be transitioned to transplant. And so Veneza is a practice-changing regimen for untreated AML patients, but in this group of patients who have had hypomethylating agents either for MDS or AML, we really need to be looking for alternative approaches. And then the last abstract that I'll talk about is a follow-up on the Admiral Study, which was done in FLT3 positive AML, and compared gilteritinib to best standard care. And this study looked at 2 years beyond the initial data cut that was reported in the New England Journal of Medicine. So at the 4-year cut, I found very interesting. 17% of patients looking at an intent to treat analysis were alive. The majority of the patients were in the gilteritinib arm versus the standard of care arm. 26 of the 49 patients in the gilteritinib arm were alive and without relapse. 18 of the 26 had undergone a stem cell transplant, although interestingly, a small proportion of patients were still on gilt alone. So there were no adverse events noted between year 2 to year 4. And the learning point we can take from this is that gilteritinib really has been an important addition to relapse FLT3 positive AML. And at 4 years, a small proportion of patients can stay on this therapy continuously, and be disease-free. So with that, I'll stop and we can open the question and answer session, I guess.
I think Dr. Poluto still is going to
Oh.
discuss the phone.
Okay, all right.
All right, back for more. So similar to the cell therapy or to the cell therapy slides, I selected a few studies I think have the most potential for clinical practice changing in the near future. I want to start with T-cell lymphoma, which is really an area of need. And I select the study of romidepsin with lenalidomide in peripheral T-cell lymphoma, looking at patients that were newly diagnosed, older than 60 or unfit for chemotherapy. Romidepsin was given, this regimen was given over 12 cycles or up to 12 cycles of 1 month length. Romidepsin given weekly for the first 3 weeks, and lenalidomide used it actually at a higher dose of 25 milligrams for 21 days. There were 29 patients treated with this regimen. Just over half of those were angioimmunoblastic T-cell lymphoma patients. Median age was 75, so being older than the average patient expected based on the inclusion criteria. Most had advanced stage disease. Median follow-up was only 8 months, but the overall response rate was 75% with 30% CR. So in this space, that's what we usually see as far as response rate with standard of care. The duration of response was only 4.2 months overall, but those patients achieving a CR had a much better duration of response, as we can expect. As far as safety, here we can see hematologic toxicities of grade 3 or higher in about half of the patients, and non-hematologic toxicities also about half of the patients with hyponatremia being the most common. So usually in this space, in untreated PTCL lymphoma patients, we rely on BV chip for those that are CD30 positive, or CHOP, depending on the age, for those that are CD30 negative. So in my opinion, I think this is an interesting regimen for the newly diagnosed PTCL lymphoma patient that is unfit to receive anthracycline-based therapy. So moving to follicular lymphoma, we have a couple interesting abstracts were presented at ASCO this year, looking at checkpoint inhibitors. I think, and I said they're interesting because we know checkpoint inhibitors don't work very well in the aggressive large B-cell lymphoma population. So this one was looking at obinutuzumab, atezolizumab, and lenalidomide in relapsed refractory follicular lymphoma patients, or 6 cycles of this drug combination followed by maintenance with obino plus atezo for 2 years and lenalidomide for 1 year. It's a phase 1b, phase 2 single-arm study. There were 38 patients that were treated in this study. The median age of 62 is what you expect to see in this patient population. The flip score distribution is also similar to what the expectation. Interesting, 37% of patients had a POD24, which is a progression of disease within 24 months from prior therapy and on poor prognostic marker. The follow-up was 3 years in this study. You can see here a CR rate of 72%, and even for the POD24, the CR rate was 50%. Interesting was the MRD negativity rate of 76% in this patient population. Here's the Kaplan-Meier curve and the 36-month PFS. I just want to highlight in the table here that the 36-month PFS was overall similar across the different subgroups, including disease double refractory and POD24. Of course, it was different for those with MRD positive disease with a 0% 36-month PFS. As far as safety and tolerability, there are a lot of grade 3 or 4 adverse events. The majority of patients had at least one of those. For the immune-related adverse events, I don't think it was much different than what we expect to see with checkpoint inhibitors. It's about treatment discontinuation in 13% of patients during induction and 16% of patients during maintenance. So in my opinion, my take-home point for this study is that it seems feasible to include checkpoint inhibitors in this combination of IMiD with CD20 monoclonal antibody. I didn't see any safety signals in this study. I think it would be very nice in the future to see a head-to-head comparison of the double, CD20 IMiD plus the triplet to see how much benefit the checkpoint inhibitor is adding to the doublet. Another very interesting study was the Floral Study. Here they're looking at immune priming with nivolumab, followed by nivo plus rituximab in untreated or newly untreated follicular lymphoma patients. So the study started with 4 doses of nivo. If patients achieved a CR, they will go to receive another 4 doses of nivo, followed by nivo maintenance. If they had anything less than a CR, they would get nivo plus rituximab, followed by nivo plus rituximab maintenance therapy. This was a phase 2 single arm study, and interesting. So 39 patients treated in this study, at least from the last update at ASCO. Median age 54, so a little younger than what we expect to see for this population. High risk, intermediate risk flip scoring, most in the majority of the patients is expected in a median follow-up of 17 months. The rate of adverse events, grade 2 or more, was 41%, and the overall response rate was 92%, with just over 50% of complete remissions. I was curious to see what was the CR rate following the first 4 doses of nivo only. So I found a swimmer's plot from ASH a couple years ago, and there was 1 patient out of 19 that achieved a CR only with nivo after 4 doses. So as you can imagine, most of these data or most of the results are patients that received nivo plus rituximab. As far as safety tolerability, they seem very fairly well tolerated. There are some infections in a majority of the patients, but all grade 1 and 2. As far as immune-related adverse events, nothing unexpected from what we know from checkpoint inhibitors. So my take-home point from this abstract was, again, the use of checkpoint inhibitors may have a role in the indolent non-Hodgkin's lymphoma. It would be nice to see a bigger study or even a head-to-head comparison, like I mentioned with the previous study. So moving to the diffuse large B-cell lymphoma space, there was an update on the L-MIND study with long-term follow-up. The L-MIND study was looking at the combination of tafasitamab, an anti-CD19 monoclonal antibody, with lenalidomide. So taf and len are given for 12 cycles, followed by a maintenance of tafa for both patients that were progression-free. Here, the patient population of relapse refractory DLBCL patients with 1 to 3 prior lines of therapy. There are 81 patients treated in this study with a median follow-up of close to 3 years. The overall response rate was almost 60% with about 40% CR and a PFS of close to 1 year. Here you can see that in these graphics that patients achieving a CR had a better PFS and OS, which is not unexpected. As far as safety of this regimen, you see a decent degree of neutropenia, grade 3 or more neutropenia in about half of the patients. There are also some infections noted as grade 3 or more, such as pneumonia and neutropenic fever reported. So my take-home point from this study is reaffirming the utility of tafa plus len as a salvage regimen. In practice, we usually use this regimen post-transplant or post-CAR-T failure for those patients that are candidate for that, or as a usually second, third line of therapy in those that are not candidate. Competing with this regimen is Pola-BR, which is also quite active and effective regimen in this patient population. So finally, moving to mantle cell lymphoma, which is very close to my heart. There was a nice study looking at venetoclax, lenalidomide, and rituximab in untreated mantle cell lymphoma patients. Again, the induction component of the study was using these 3 drugs for 12 cycles. Lenalidomide at 20 milligrams here, rituximab was given weekly in the first month, followed by every other cycle, and venetoclax, daily following a ramp up a dose aiming for 400 milligrams daily. There was quite of a long maintenance with venetoclax for 1 year, lenalidomide going all the way down to 2 years, and rituximab all the way down to 3 years of maintenance. There were 28 patients who were treated on this regimen. I couldn't find a median follow-up anywhere, but the overall response rate was 96%. And you can see here in the table that most of that came from complete remissions. And interesting also, the MRD negative status was 71%, which is a very good rate of MRD negativity. As far as safety and adverse events, There was a great degree of cytopenias, which is not unexpected when you combine venetoclax with lenalidomide. But there were no treatment discontinuations during this study. A couple cases of secondary malignancies, including adenocarcinoma of a non-primary and a cutaneous squamous cell carcinoma. So my take-home point from this study is that this treatment combination has some deep responses in untreated mantle cell lymphoma. Will be a reasonable option to use. I think in mantle cell lymphoma space is moving and following the CLL space, trying to get away from the cytotoxic chemo regimens earlier in the treatment course. It's a little bit disappointed to see that patients with p53 mutation at baseline didn't respond as well, but I'm curious to see when you have more data presented or the final results presented, have a better idea of how the p53 mutated patients did with this combination. I think that's my last slide. Thank you so much. Thank you for the patience with the difficulties with in finding the PowerPoint presentation.
9 more minutes of questions. Maybe I'll ask the first theoretical one. R-CHOP has not been able to be beaten in diffuse large B-cell lymphoma for 30 years. Between TAFA and bispecifics, do you think we're finally going to replace R-CHOP in the next 5 to 10 years?
That's a tough question. I mean, if I look back, I think it would be challenging to beat R-CHOP. Of course, we have to see, there's so many different drugs have been, compared against R-CHOP, and you keep losing it. R-CHOP keeps beating it. So, I would bet my money on R-CHOP, but hopefully we'll find something that can actually beat R-CHOP and give us even better results. I can't repeat the question. So the question was in practice, how do we manage smoldering multiple myeloma? So, of course, the standard of care is observation at this point. And full disclosure, my main practice is lymphoma and cell therapy. So I don't often manage patients with myeloma. Although there are some clinical trials looking at active management of smoldering myeloma. So off trial, I would say observation.
I guess we can break it early then. Thank you very much.
Thank you.